So that's my disclosure statement. I do not have any financial relationship with any proprietary entities producing, marketing, reselling, or distributing health goods or services. So learning objectives for today's talk is to have a systematic approach in evaluating brain CT, how to adjust CT brain window, to recognize and describe the early signs of acute ischemic stroke, and then the aspect score. So what is a stroke CT? It's just an ordinary CT scan. It is done without contrast. There are 5 millimeter cuts in the posterior fossa, 3 millimeter cuts in the supratentorial region. And the region covered is from the skull wall to the C2 level. We do in the brain window, and CT scan is performed in axial cuts, and then there are recons in the coronals and sagittals. It has a very fast acquisition time. So this is my systematic approach to interpretation, which I also presented at ARRS in April 2018. So how you interpret a CT scan and how much time does it take? It hardly takes 2 minutes time to evaluate CT brain for the acute stroke patient. Like almost always see the scout image, which hardly takes 5 seconds, then just scroll from the skull vault to the skull base, which is known as quick first pass, which hardly takes 10 seconds. Then ABBCS system, which takes about 40 to 45 seconds. And then you have to focus your search pattern, which is in the MCA territory or the AC or PCA territory, depending on the signs and symptoms, which takes about 50 to 60 seconds. So what is the ABBCS system? A means asymmetry, you are comparing one side with the other. B stands for blood, you are searching for anything which is hyperdense to the brain. The other B is you are also looking for the abnormal density, like the hyperdensity, acute blood. We don't know we are dealing with a tumor. Is there any bone, dural sinuses, displacements? You have to see the midline shift. Is there a midline shift? You also look for the midline structures, because sometimes there is a tumor in the fox which is compressing the brain, and then you are seeing the signs and symptoms of weaknesses. Asymmetry of CSF spaces, then effacement of the cisterns and tonsillar herniation. And obviously you have to look for the gray and white matter differentiation, but for that you have to adjust window to see the early signs of infarction. Always look for the CSF spaces. CSF spaces are the ventricles, sulci, and cisterns, because you never know, patients come with subarachnoid hemorrhage, then secondary vasospasm and infarctions. In CSF spaces, you have to see the size of the ventricles and sulci in proportion to each other and the brain parenchyma. You have to see the normal cisterns and fissures. Pathology may be primary within the ventricle or may be result from compression. Diffuse brain swelling can result in ventricular compression and decreased conspicity of the normal sulci and gyral pattern. Skull and scalp is also very important while you are reading a CT scan for the stroke patient, especially in patients where a full history is absent, and assess the scalp for soft tissue injury. It also helps to localize coup and counter coup injuries, assess the bone vault for underlying soft tissue injury for evidence of a fracture. What you're looking in the skull vault or the skull bone, you're looking at the shape, symmetry, and the mineralization. And obviously you have to, CT scan is about window settings, so you have to adjust window to optimize bony details. So how to adjust CT window? There are multiple CT windows in the literature in radiology, that which one is the best for the detection of early signs of a stroke. But over the years, what I have concluded, every eye has a different resolution, and now this is recommended that every eye has a different resolution settings. So wherever you see a better gray and white matter differentiation, not at the level of basal ganglia, but in each gyrus, then that is the window for your eye. Like till now, the window width and window level setting which is recommended is 35 to 35. In CT scan, let me tell you a few things about CT scans. CT scan is just about a window setting. It's just like you're looking at the brain through a window. So there is window width, like there's a range of Hounsfield unit, and then there's a window level at which you have to see the scan. So it should be very narrow. Window width and window level They should have a very narrow range of difference. That is the level where you can see the better gray and white matter differentiation, and you can pick early signs of a stroke. So what are the signs of acute ischemic stroke? There's loss of gray and white matter differentiation. There are hyperdense artery sign, which may be MCA, Sylvian, PCA, basilar, then insular ribbon sign, disappearing basal ganglia sign, gaze deviation, calcified emboli, and laminar necrosis are not particularly for the early signs of acute ischemic stroke. So loss of gray and white matter differentiation, as you can see on the right side. So on the left, if you compare the both temporal lobes, you can see this is the gray matter, and over here you can see the white matter, but on the right side there's loss of gray and white matter differentiation. Similarly, on the image on the right side in the left frontal lobe, you cannot differentiate between the gray and white matter differentiation. So this is a sign which is known as loss of gray and white matter differentiation. Hyperdense artery sign, you can see the density of the vessel. It's a non-specific sign, because some patients who have high hematocrit level, who are dehydrated, their vessels can also be hyperdense. But there are certain HU levels, like if it's more than 60 Hounsfield units, the vessel is expanded, then it's more likely there's a thrombus in it. Sylvian artery, I found it a more reliable sign than the MCA dense sign, because the more peripheral you are going, there are less chances of atherosclerosis. So if a vessel is hyperdense, then it's more likely there is a thrombus in it. Then hyperdense basilar artery sign, hyperdense posterior cerebral artery signs. Now coming over to the parenchyma insular ribbon sign, again you are looking at the gray and white matter differentiation of the insula and the subinsular region. When there is loss of gray white matter differentiation in the insula, this is known as insular ribbon sign. Similarly, the disappearing basal ganglia sign, this is from like very basic teaching. If you cannot differentiate between the basal ganglia and the internal capsule, that means there is disappearing basal ganglia sign, and this is an early sign also. Gaze deviation, it's like in the aspects literature. So when it's an indirect sign, when you are not able to find any sign, then look for they say you can go for the gaze deviation sign. The gaze is deviated mostly towards the side where there is a hemispheric stroke. Calcified emboli, when the calcified embolus, calcified thrombus is embolizing, then you can see calcified emboli at the site of infarct, and laminar necrosis is also a sign of a stroke. And how to differentiate laminar necrosis from the subarachnoid hemorrhage? The laminar necrosis is hyperdensity within the gyrus, and subarachnoid hemorrhage is hyperdensity in the sulci. So now coming over to the Alberta stroke program early CT score, it's a 10-point quantitative topographic CT score used in patients with MCA stroke. Although now people are also talk about PCA stroke, Alberta and the PCA stroke as well. But I'm focusing only for the MCA. So the scoring system is, there is segmental assessment of the middle cerebral vascular territory, and 1 point is deducted from the initial score of 10 for every region involved, like the chordate, putamen, internal capsule. Initially, when the aspect was there, so people were talking about which part of the internal capsule, because the internal capsule has anterior limb, genu, and the posterior limb. So then it was concluded that the posterior limb of the internal capsule has the maximum density of the fibers. So the posterior limb of the internal capsule is more important than the anterior limb of the internal capsule. Then insular cortex. M1 is the anterior MCS cortex corresponding to the frontal operculum. M2 is the cortex lateral to the insular ribbon, which corresponds to anterior temporal lobe. M3 is the posterior MCA cortex, which corresponds to the posterior temporal lobe. M4 is the anterior MCA territory immediately superior to the M1. M5 lateral immediately superior to M3. M2 and M6 is superior to M3. It's very easy to calculate on the CT scan. Like we have thrombectomies. So what I teach our radiology residents and our neurology residents and instructors and attendings, that it's very easy to calculate aspects at the time when the patient is on the table. Just open these two levels, one at the level of the frontal horns and the other just above it where there are body of the lateral ventricles, and just adjust the window and just you can start marking the aspect score. So this is the caudate nucleus. This is the lentiform nucleus. The gray area between them is the internal capsule. The area lateral to the lentiform is the insula. Then at the level of the frontal horn, the frontal lobe is M1, temporal lobe is the M2, and M3 is posterior to it, is the posterior temporal lobe. And when you go just one level above it, which is at the level of the body of the lateral ventricle, M4 is just above the M1, M5 is above M2, and M6 is just above M3. It's easy. So when so if you are asked to calculate aspects in this patient, so you can see, comparing from the right side, there is loss of gray and white matter differentiation in the caudate lentiform internal capsule, as well as there is loss of gray and white matter differentiation in the left anterior as well as the posterior temporal lobe. But the left frontal lobe pattern is preserved of the gray and white matter differentiation. It's almost similar to the right side. And when we go just one level above, at the level of M4, 5, and 6, there is again loss of gray and white matter differentiation in each gyrus. So this patient has the aspect score of 1. Similarly, another patient, you can see well-preserved gray and white matter differentiation at the level of basal ganglia. M1, M2, and M3, everything is preserved. Insula is preserved, and M4, M5, and M6. Again, gray and white matter differentiation is preserved in each gyrus. So this is 10 by 10. So concluding my presentation, when you are reading a stroke CT, you should know where to look and what to look for. You should have a systematic approach to interpretation. You should have a proper windowing for the brain parenchyma. And for the systematic approach, it's better to follow ABBCS system, or any system in which you can rule out bleed, you can rule out midline shift, and you can rule out anything else which can mimic clinically as a stroke. Thank you very much.